Hello, my name is Dr. Debar Rasoul. I'm a cardiology registrar working in the Mersey Northwest Deanery, carrying out a programme doing my MD with Dr. Sanker at Liverpool University Hospital NHS Foundation Trust and Professor Gregory Lipp at the Liverpool Centre for Cardiovascular Science at University of Liverpool. This is a short video to go alongside our feasibility study poster, which you can also attend a talk on stage on Friday for. For background, acute decompensated heart failure contributes to frequent hospitalizations and prolonged length of stay in hospital, with the average length of stay being 9.2 days in hospital. In our trust, we have previously demonstrated safety and efficacy of outpatient management of acute decompensated heart failure with bolus IV diuretics, and our abstracts have been publication circulation. In Liverpool, we have over 10 years of telehealth experience in managing conditions like heart failure, COPD, diabetes, and we have shown a reduction in unplanned hospitalizations. However, acute decompensated heart failure management guided by telehealth has previously not been assessed. So following a £240,000 digital transformation award from the NHS Transformation Agency, we developed the UK's first true heart failure virtual award, led by our trust Luft, the Merseycare NHS Foundation Trust, Docabo, and the University of Liverpool. We undertook a feasibility study between May and November this year and assessed the outcomes of our new digital heart failure pathway, which comprises of telehealth guided outpatient management of acute decompensated heart failure in a virtual ward, where we transmit the clinical parameters to a telehealth hub and our Docabo web via a Docabo Care portal or a smartphone. I've got pictures of these later down in the presentation. We gave IV furosemide to patients with a median dose of 200 milligrams, ranging from 120 milligrams to 480 milligrams, either at home or in the outpatient heart failure ambulatory unit. We gave them as bolus at 4 milligrams a minute using an elastomeric pump, and a pump to care blood testing was utilized, which I've also got pictures of. We then assessed all patients' clinical risk scores, such as Get With The Guidelines scores, their comorbidities using a Charlson's Comorbidity Index, and their frailty score using a Rookwood Clinical Frailty Score, ultimately with a view to look at short-term outcomes such as 30-day readmission and 30-day mortality, comparing our heart failure virtual ward cohort patients to patients that we manage without telehealth for acute decompensated heart failure into 2021, what we call standard care. This is our flowchart for the virtual ward. Patients would be referred in from any of the referral sources, such as A&E or AMU, to try to prevent admission, or from the wards where we supported early discharge. Patients also could be referred in from the community heart failure team. If they meet the eligibility criteria, they are onboarded onto the virtual ward and they get access to a heart failure passport app, which is a talk that I will be holding on Friday as well. On the virtual ward, they can stay for about 14 days, where they get daily questions and their clinical parameters measured 3 times a day. They get regular nurse phone calls, but ultimately they get a daily heart failure consulting review in their case, 7 days across the week, between 8 and 8 p.m, where the nurses meet with the heart failure nurse once a day. If their symptoms are improving and the volume state is improving, they can be ultimately discharged to long-term conditions, remote monitoring, or discharged back to their GP with discharge letters and advice. If their symptoms are worsening, such as an increasing weight gain or any other symptoms that fall within the amber flag symptoms, then we can have higher level of input, so we can increase the furosemide therapy, we can change the oral therapy, we can consider them for an increase in their device therapy if they're suitable, or ultimately, unfortunately, if they're not getting any better, then we can initiate palliative care early. If patients display and complain of red flag symptoms and it's out of hours, we ask them to come to A&E. If it's in hours, we try to make available space in the ambulatory unit for us to review them. So whilst on the virtual ward, we have a couple of innovations that we make use of. First of all, this is an example of the Docabo Care portal system, where patients can answer the questions, they can get their ECG monitored, and there's also scope for video consultation and taking pictures of things they might find relevant, such as rashes or whatever it may be. The nurse that goes into their house have access to point-of-care blood testing systems, where we've shown previously that you can get a blood result within 5 to 10 minutes. Previously, when we studied this, our average return time from the lab was 61 minutes, meaning that a healthcare professional could get into the house, get a blood sample, and whilst they're there, get the result and make clinical decisions and medication changes there and then. And the last picture there is the elastomeric pump that we use. This is a far less bulky and easy to carry on for the nurse than traditional pumps. It doesn't require any electricity, and when the patient's wearing it, allows for far more maneuverability as well. This is an example of the data that we can obtain while the patient's on the virtual ward, and this is our Docker Web screenshot. As you can see here, we see parameters such as pulse, body weight, blood pressure, saturations, and body temperature. And interestingly, in this patient in particular, you can see when the body weight has got a nice steady decline whilst they're on the virtual ward. On the right hand side of the screen, you can see step count at the top, where you can see that the step count of the patient increased steadily from onboarding to when these pictures were taken. This table underneath in green and red is examples of the questions that we ask. And we use a traffic light system for ease for the patients, but also for the nurses and the healthcare professionals. So for example, in this case, you can see the questions about ongoing and increasing breathlessness were flagging in the red early parts of the virtual ward when their weight was high and the mobility was low. And towards the latter stage, you can see that their questions fall in the green category. So thus far, 190 patients have been recruited. The median age is 73 years, but we also have 30% of our patients above 80 years. Half are women, and so far 71% have received IV diuretic therapy either at home or in the ambulatory unit, and the remaining 29% have had an escalation in the oral diuretic therapy or the medication therapy. Whilst on the ward, we've had multiple patients being considered for advanced device therapy, and we've even had the patient referred to transplant while on the virtual ward. When we look at the data, these are our virtual ward cohort compared to a standard care cohort. Have shown very similar clinical parameters, both in their comorbidities and their frailty. But ultimately, what we have managed to show is a 30-day all-cause rehospitalization reduction and a 30-day mortality reduction. When we looked into these readmissions in more detail, we found that nearly 90% of these readmissions were due to non-heart failure causes. So in conclusion, we've shown that our model of heart failure ward seems to work, and it showed a reduced 30-day readmission and mortality for us. If this model was to be implemented elsewhere, I think it needs adapting based on local expertise and availability of staffing and resources. Thank you very much for your time.